Hello, and welcome to the Illinois DocAssist webinar on trauma-informed mental health care. My name is Kelley Volpe, and I'm a child and adolescent psychiatrist and a DocAssist consultant. Illinois DocAssist presenters have no relevant financial relationship with the manufacturers of any commercial products and/or providers of commercial services in this presentation. Illinois DocAssist presenters do not intend to discuss commercial products, services, or unapproved investigative uses of a commercial product or device in this presentation. Today, we will be discussing trauma-informed mental health care. We will examine the impact of childhood trauma and mental illness on the lifespan. We will apply skills to recognize trauma-related disorders and utilize tools for screening and diagnosis. We will also be reviewing the evidence for treating trauma-related disorders in children in order to determine the best treatment plan. Let's start with a clinical case that we will be reviewing as we move through the presentation. For this case, you are the primary care provider for a 12-year-old boy and his 10-year-old brother, and have been their provider for the past 5 years. The boys come in annually for well child visits. They have been to urgent care twice in 5 years for ear infections, but otherwise are healthy and developing normally. They live at home with their biological mother, her long-term boyfriend, and their maternal grandmother. They do not see their biological father. Their grandmother attends most visits with them. They are reluctant to directly answer your questions. I'd like for you to pause for a moment and think, how would you screen for trauma with this family? Let's continue the case. During each visit, you note that both boys often have bruises in various locations on their bodies. Every time you note this, you ask the family about the origin of the bruises. They consistently reply the bruises are due to rambunctious play. Both brothers consistently deny any abuse. Take a moment to think, would you take any further steps at this time? Let's continue to keep this case in mind as we discuss what is trauma and its related risk factors and symptoms. The DSM-5 defines trauma as exposure to death, injury, or sexual violence by either direct experience, witnessing in person the event as it occurs, learning about a traumatic event that occurs to a close family member or friend, or experiencing repeated or extreme exposure to adverse details of the traumatic event. For example, first responders might experience this. But trauma is not just limited to the DSM criterion A. It encompasses a broad range of events, including exposures to violence, natural disasters, divorce, being separated from parents, and other adverse childhood experiences. These events and experiences can impact people across their lifespan, especially if they occur in childhood. We can take a closer look at some of the adverse childhood experiences that have been studied. The Adverse Childhood Experiences Study was conducted at Kaiser Permanente from 1995 to 1997. This study surveyed over 13,000 members with questions about childhood maltreatment and family dysfunction, as well as items detailing their current health status and behaviors. In addition, more than 17,000 participants had standardized physical examinations. Through this study, researchers were able to gather much information about the impact of adverse childhood experiences on the population. Let's look at some take-home points from the ACEs study. First, we can see what populations are most vulnerable to experiencing ACEs. There were certain parent and caregiver characteristics that put children more at risk of these experiences. These parent characteristics included parents at a young age, lower education level, single parenthood, large number of dependent children, lower incomes, a personal history of abuse or mental illness, poor parenting skills, as well as having multiple transient caretakers. Additional risk factors included exposure to community violence and poverty. One final risk factor was children with chronic medical problems and special needs were at higher risk than the general population. Another important take-home point is the increased morbidity and mortality associated with ACEs. There was an increased risk of activities that led to worse health outcomes as an adult. This included smoking, not exercising, and obesity. In addition, they found an increased risk of depression and suicide for participants who were exposed to ACEs. The risk of morbidity and mortality increased with the amount of violence and trauma to which one was exposed. These high-risk activities and symptoms can be conceptualized as ways of coping with exposure to trauma. Our next take-home point is that these experiences are highly prevalent. When responding to the study, at least 64% of people reported one or more adverse childhood experiences. The most common adverse childhood experience reported was substance use in the household. This study showed a clear connection between ACEs and early death, showing us that trauma has not just an impact on mental health, but also physical health. All of these take-home points, including the increased morbidity and mortality, the high prevalence of trauma, and the high-risk populations, further support the need for universal screening and providing trauma-informed care. Trauma-informed care is a framework used to understand and treat patients exposed to trauma. Trauma-informed care realizes trauma's widespread impact on paths for recovery. It recognizes the signs and symptoms of trauma and responds. The goal of trauma-informed care is to prevent re-traumatization and to improve outcomes. Another term that is commonly used is healing-centered engagement, because the focus is not just on treating trauma, but also on promoting recovery and resilience. Trauma-informed care can be implemented in any type of service setting and is distinct from trauma-specific interventions or treatments. To provide trauma-informed care, awareness is key. We know that early intervention improves outcomes, so steps should be taken in order to intervene as early as possible. This includes screening and assessment. Trauma history is often missed, and standardized screening and assessment can help this. Knowledge about trauma is crucial to providing care for our patients. Knowledge about trauma improves secondary prevention. This allows providers to give anticipatory guidance and appropriate referrals. Awareness is also incredibly important because working with this population can increase provider burden. Knowing about this potential impact can help providers seek support when they need it. Let's return to our clinical case. At your next appointment, you see the brothers brought in by maternal grandmother. She pulls you aside to mention, "I'm concerned the mother's boyfriend could be responsible for the boys' injuries." However, when she asked the boys, they both told her it wasn't true. She is concerned because their grades are dropping and the older brother is very aggressive towards the younger brother. During the physical exam, you again note leg bruises. You ask the patient if he feels safe and if anyone has ever hurt him, including his mother's boyfriend. He denies being hurt by anyone, but describes being picked on at school. The younger brother also denies being harmed by the mother's boyfriend. So in this case, now we have more information and we have some basic screening, but what are the next steps? Let's take a closer look at the risk factors associated with adverse childhood experiences. These risk factors can be divided into two categories: parent characteristics and child characteristics. The parent characteristics, as you recall, include young age, low education level, single parenthood, having multiple children in the home, low income, a personal history of abuse or mental illness, as well as poor parenting skills. The child characteristics are children who are exposed to community violence, children with chronic medical problems, children with special needs, and having inconsistent caregivers. As previously discussed, trauma is very common, and therefore universal screening is appropriate. However, there will be times where more high-yield and in-depth screening is needed. Another indicator for this needing further screening are symptoms that are experienced by the child. These are often not just typical PTSD symptoms, but rather can impact a range of diagnoses. These symptoms can be conceptualized into two different categories as well: internalizing symptoms and externalizing symptoms. Internalizing symptoms include anxiety, depression, social withdrawal and loneliness, as well as somatic symptoms such as headaches and stomach aches. Externalizing symptoms may include conduct and oppositional behaviors, physical aggression, destruction of property, running away from home, and substance use. There are many ways to screen. A good place to start is with a basic clinical screening. This includes questions that you would ask the family. The screening should begin with an initial question, such as, has anything scary or upsetting happened to you or your family since our last visit? This will assess if a traumatic event may have occurred. This should be followed with a follow-up question, such as, does what happened ever bother or upset you these days? This is used to assess the impact of the traumatic event on the patient and family. Screening can also occur in a more structured and standardized way. This typically includes the use of screening forms. Using screening forms often takes the same pattern as a clinical screening. You can use an initial screening form, which is often just a checklist of ACEs. This should be followed by follow-up screening forms for anyone who endorses having experienced a childhood stressful and adverse event. This might include specific screening for PTSD or other screening for depression, anxiety, and other mental and behavioral health problems. Let's take a closer look at some of these screening forms. This initial screening form is called the Life Events Checklist and is available through SAMHSA. As you can see, it lists below multiple events that can have occurred since the last visit. Children and families can check if it happened to them, if they witnessed it, if they learned about it, or if they're not sure it doesn't apply. If an initial screening is positive, then it is important to do a follow-up screen to assess the impact of the trauma on any symptoms that the patient may be having. One such screening form is the Children's Revised Impact of Events Scale. This scale is a self-report measure for children 8 and above, and it asks about any PTSD symptoms that they may have experienced in the last 7 days. These common symptoms of re-experiencing and avoidance are questioned. With a combined use of 2 subscales, a combined score of 17 or higher is indicative of a positive screen. The false positive rate is low, but as with any screening form, it is important to correlate clinically to ensure that the diagnosis makes sense for each individual patient. Additional screening forms may be needed to check for other diagnoses that are often impacted by trauma. Forms such as the SCARED and Spence Child Anxiety form can assess for anxiety disorders in children as young as preschool age. It also includes subscales related to OCD. The PHQ-9 assesses for depression symptoms. It also includes a modified version for teens that includes more in-depth questions about suicidality. The Vanderbilt Assessment Screening Form is mainly for ADHD, but also includes subscales for anxiety, oppositional defiant disorder, conduct disorder, and depressive symptoms. The Pediatric Symptom Checklist is a 17-question general screening for internalizing, externalizing, and attention problems that children may experience. This can be used for children and adolescents. All of these screening forms and others are available on the Illinois DocAssist website. When utilizing screening forms, it's important to consider implementation. Screening forms should minimize burden to clinician and patient while maximizing the benefit. Some factors to consider are, is the form easy to complete? Does it gather information quickly? Are the forms standardized, usable, readable, and can they be easily integrated into your usual clinical care? Oftentimes, this might mean being used in the waiting room or while trainee is staffing with the attending. It's also important to remember when giving a screening form to a patient to review the screening form before the patient leaves, just in case there's information in there that needs to be addressed at that visit. How might this work in your clinic? This algorithm is one way you can incorporate screening forms into your clinical practice. This algorithm includes both universal screening, because trauma is highly prevalent, and selective screening for patients with risk factors for an adverse childhood experience. New patients and high-risk patients should be screened at every visit. This initial screening can include an adverse event form, such as the life experiences checklist. If this form is negative, continue to screen high-risk patients at every visit utilizing the risk factors discussed on the previous slide. If the initial screening is positive, administer a follow-up screen. This may include specific screening for PTSD, general screening utilizing a pediatric symptoms checklist, or specific screenings for depression or anxiety disorders. If this screen is negative, these patients should be screened for symptoms at each subsequent visit. Because they have experienced a trauma, they have entered a high-risk group for developing related symptoms. If the follow-up screen is positive, you must take a very important step, a safety assessment for suicide. As we learned on a previous slide, patients who've experienced trauma are at a higher risk for suicide than the general population, especially if they have related psychological symptoms. This includes checking for suicidal thoughts, intent, and plans. If these symptoms are present, the patient may require hospitalization. Including family members in developing a safety plan is very important when working with children and adolescents. After a safety assessment, the next step is to triage their symptoms and develop a treatment plan. Symptoms should be categorized into mild, moderate, or severe, based on how many symptoms occur and how severely they are impacting the patient's functioning. For patients with mild symptoms, therapy or brief behavioral intervention is recommended. For patients with moderate symptoms, they should be referred to an evidence-based therapy. Patients with severe symptoms may require medication treatment along with the evidence-based therapy. For all patients who have screened positive, their symptoms should be followed up at subsequent visits to check for treatment response or symptom persistence. The standardized screening forms utilized for the follow-up screening can be utilized for this purpose as well. Scores on the forms can be followed over time to look for trends to recovery or otherwise. Let's go on to take a closer look at evidence-based treatments for trauma-related symptoms. The first step of treatment when responding to reported trauma is to continue to do the things that you are already doing as a patient's primary care provider. First, primary care providers are safe adults for children and their families. This is because they are calm and reassuring. They see children for routine and non-judgmental reason, and they fix things. All of these aspects build a relationship between the primary care provider, the children, and the families. This relationship is an important part of feeling safe for children and can provide support in difficult times. Second, a large part of the primary care provider's job is to provide education to families. This is also helpful when responding to a trauma. Primary care providers can provide education on the effects and course of trauma, on the importance of mental health treatment if needed, and also give anticipatory guidance on what they may expect. Primary care providers can also provide treatment of medical complications related to the trauma. This may include injuries or other more chronic illnesses like asthma or recurrent GI distress. Providing care continues to support the relationship and bond between the primary care provider and their family. Primary care providers also provide ongoing monitoring. Just having had trauma doesn't automatically require treatment, but it can be conceptualized as a risk factor for diseases that do need treatment. Primary care providers can educate the family on this, as well as provide monitoring for any symptoms that may require mental health treatment in the future. As we continue to discuss the management of trauma and trauma-related symptoms, let's return to our clinical case. A while later, the patient presents to the emergency room with a broken leg. An X-ray shows a spiral fracture of the femur. In the emergency room, he again denied being harmed. At their follow-up appointment with you, their primary care provider, maternal grandmother tells you that the boys admitted being physically abused by their mother's boyfriend. Grandmother asked why they didn't say anything when they were asked before. The boys tell you they were scared because he had threatened to hurt their mother. They promised each other that they wouldn't tell anyone in order to protect their mother. Let's take a moment to think. How was their denial protecting mom? What other reasons might they have had? Threats and intimidation are commonly used by perpetrators of child abuse to prevent themselves from being revealed. It's important to be aware of this because the threats and intimidation often will keep children from reporting. This means that a provider might need to take steps to keep the children safe before they even receive a report. In this case, the primary care provider did receive information that the children were being abused. How to respond when a trauma is revealed can be highly individualized, but there are basic guidelines that can be followed. The first response when a patient reveals a trauma should be to empathize and normalize. This may include providing an empathic response, such as, "I can tell this is difficult to talk about," or a statement to help them understand that trauma is common can help to normalize the situation for them, such as, "I often see children who have had these kinds of experiences." It can also be helpful to normalize their emotional or behavioral reaction by letting them know that it is normal to feel scared, hurt, unsafe, or stressed. Another very important part of the initial response is listening. Allowing the patient or family to express what happened their own way initially can help to build a supportive alliance and a safe space for patients to report difficult things. This may mean a patient giving very little details or very many details. It is okay to ask some questions, but there isn't a need to push if a patient doesn't want to share those details initially. One of the most important aspects of listening is using silence. Silence allows both the provider and the patient to sit and think about what has happened. Moving on quickly can reinforce patterns of ignoring emotions or trauma and not taking time to understand and build resilience. And understanding silence can help to build a supportive alliance between the provider and patient. Silence can be difficult, especially since as physicians we are trained to help and to solve problems. When a patient is revealing a trauma, they may pause when they get to a difficult part. There's a natural instinct to fill in the blank because it seems like the kind thing to do, to help them put words to the awful experience when they seem to be lost about what to say. They are vulnerable in that moment, and why would we want to leave someone hanging in this vulnerable state when we could so easily make a supportive suggestion? This is where the silence should linger. The patient has the opportunity to decide to continue with their own words, or if that is all they want to say for now. Utilizing silence helps the patient have time to translate the emotions into meaningful and descriptive language. It also helps the patient understand that the provider is there to support and listen. After the initial empathic response, the next step is for the provider to give education. This education should include anticipatory guidance on what a patient and family can expect, whether related to symptoms or the need for further treatment. A patient may be revealing a trauma that is past or a new trauma that has happened recently. They may also reveal psychological or physical symptoms related to the trauma. The education should focus on whichever of these the patient has revealed. A provider might need to educate on particular mental health diagnoses or physical diagnoses related to the trauma, as well as plans for management. If the trauma that is reported is a new trauma, a big part of the anticipatory guidance is to help them understand that symptoms of anxiety and fear are normal after experiencing a trauma and don't necessarily require treatment immediately. Instead, the first step in management is to continue to assess, returning to the primary care provider for a follow-up appointment in 1 month to see if symptoms are persistent or if symptoms are impairing their regular function is an important next step in managing new traumas. Primary care providers may also provide written information to the families about trauma and trauma-related symptoms. Written information is available through the American Academy of Pediatrics or the American Academy of Child and Adolescent Psychiatry. This might include facts for families or other standard information. Families being able to refer to the written information once they return home can help them remember all of the details in the education. An important part of providing education after a trauma is to give the family information on things they can do at home to minimize the impact of trauma-related symptoms and potentially prevent the development of other symptoms or disorders. This is where preventative maintenance comes into play. If you can predict it, you can prevent it. There are a few established ways to do this. The first step in preventative maintenance is building a support system. Communication is so important, especially between primary caregivers and children. Building communication may include educating primary caregivers about ways to communicate in a non-judgmental, supportive fashion by listening and providing empathic responses without trying to do too much problem solving or lecturing. This will also include helping the patient identify and utilize supportive family members and friends. It is also helpful to encourage extending the support system to the extended family and supportive family friends. This may include increasing time spent with family and spending time engaged in religious or cultural activities, which can be helpful for children and adolescents to develop a sense of self outside of the trauma and related symptoms. The next step is self-care. No matter the medical problem, we know that a healthy lifestyle improves quality of life and minimizes the impact of symptoms on functioning. Providing education on sleep hygiene, healthy diet, and physical activity is important. It is also important to encourage the family and patient to engage in recreational activities, such as family fun times, team or group activities, or organized extracurricular activities. Again, this helps to develop a sense of self outside of the trauma, as well as a sense of engagement in the community and mastery in life. Lastly, patients should be utilizing relaxation regularly. This may include deep breathing, meditation, or something like yoga. It can be helpful to practice in the office briefly or to provide online resources to guide the patient and the family. The previous interventions are universally helpful for patients who have experienced trauma, regardless of what type of related symptoms or diagnosis they are experiencing, even if they aren't experiencing any symptoms. Let's talk more about specific treatments for trauma-related symptoms, especially PTSD. A small percentage of patients who have experienced a trauma will screen positive for PTSD. For PTSD, therapy is the first-line treatment. If you recall from the treatment algorithm before, the need for treatment is based on symptom severity. This will include an assessment of how many symptoms they are experiencing and how the symptoms are impacting their life, such as, are they able to attend school and social activities? Are their grades impacted? Or even, are they having suicidal thoughts or actions? For patients with few symptoms and who are able to do well in school and social activities, they may not need a referral to therapy, but instead they can utilize the in-home activities discussed in the previous slide and be monitored closely. For more severe presentations, a therapy referral is recommended. When and if you are ready to refer a child for psychotherapy, it's important to know what the evidence-based psychotherapies are for trauma. This is not because you will be delivering the psychotherapy, but in order for you to be able to provide the family with the most up-to-date education about the psychotherapeutic process, as well as to find and provide appropriate referrals. It can be helpful to locate providers in your area that you know provide psychotherapeutic trauma-based interventions. This might mean speaking with some of the therapists in your area, or you can also locate therapists that provide trauma-informed interventions on the National Child Traumatic Stress Network. Let's take a little bit closer look at what are the evidence-based trauma psychotherapies. First, we have child-parent psychotherapy. This psychotherapy is specifically for young children and an abused parent. This focuses on parenting skills and ways to help the parent manage their symptoms and provide therapeutic parenting for the young child. Trauma-focused cognitive behavioral therapy is often seen as the gold standard for trauma-informed therapy and evidence-based trauma treatment. This treatment is for all ages and all different types of trauma. It is typically provided by a certified trauma-informed psychotherapy counselor. It can also include more work on traumatic grief for if a child has lost a close loved one, like a primary caregiver. In addition, there are cognitive behavioral interventions for trauma in schools. This might include a wide range of therapeutic activities, usually provided by a school counselor or school psychologist. This is more focused on peer support and doesn't typically include the parent. Other cognitive-based cognitive behavioral therapy for trauma are more focused on reclaiming life activities and resilience than processing the trauma. In addition, there's brief psychoanalytic psychotherapy for trauma. This includes play therapy and as well as sexual abuse topics and developing resilience and coping. Other types of psychological treatment for trauma have been noticed to be harmful or not have any benefit. Earlier in the talk, we discussed that immediately after a trauma, it's important to normalize, encourage preventive maintenance, and monitor for the development of symptoms, and not make an immediate referral. Remember that someone needs to have symptoms of PTSD for 1 month in order to diagnose PTSD. Psychological debriefing is a type of treatment that occurs immediately after a trauma happens. This includes giving an in-depth psychological interview to someone who's experienced a trauma. It has been noticed that this can be potentially harmful and increase the risk of developing PTSD after a trauma, and it is not recommended. Non-structured therapy, or therapy that isn't immediately focused on the trauma, is noticed to be less effective for treating trauma-related symptoms. So specific treatments for major depressive disorder and generalized anxiety disorder or other DSM diagnoses may not be as effective for someone who has had trauma, and they might need a more trauma-focused psychotherapeutic intervention. Other interventions that may come up include restricted rebirthing, holding techniques, and withholding food. All of these interventions have been deemed unhelpful as well as harmful and should be avoided. Trauma-based interventions have certain components in common that are the components of effective trauma-based treatment. It is important for primary care providers to be aware of this so that when following up with patients, you can ask and be aware if the treatment they are engaging in is a trauma-based psychotherapy and if it's likely to be helpful or not. The components of an effective treatment are drops. First of all, the treatment should be developmentally and culturally sensitive, meaning that it should be appropriate for the patient's age and also take into account the different aspects of the patient's and their family's culture. In addition, the treatment should be resiliency-based and not deficit-based. So it should be healing-centered, and it should focus on building the patient's strengths and not on what they are doing wrong. The most important part of the effective trauma-based treatment is overcoming avoidance by encouraging the child to talk instead of waiting for them to be ready. As we spoke about earlier in the presentation, initially, it's not important to ask many questions or get many details. However, as the patient goes through the psychotherapeutic process and builds their resilience, overcoming avoidance becomes an important part of coping with the trauma and completing the treatment. Therapy is more than just creating a safe space for a patient to talk. The feeling of resilience and capability needs to expand outside of the therapist's office because that's where the patient is functioning, and that's how the patient builds healing and resilience. This typically involves the patient talking about their trauma and doing what is called a trauma narrative, where they write about or draw about or speak about details from the trauma, and they do this in the office and they do it at home with their parents or family members. It's also very important that trauma-based psychotherapy be parent inclusive. Once again, For a child to be able to relate to the therapist and build a good therapeutic alliance, this is a very important part of therapy. But we also know that a child functions outside of the therapy office, and having the external support of the parent helps for the child to build resilience in a way that impacts all areas of their life. Lastly, trauma-based psychotherapy should be skilled and safety-focused to improve functioning in areas that are problematic. This includes the development of skills to help manage school, to sleep better, and to modulate their emotions. It's also important to help children feel safe and develop a safety net outside of the trauma. Let's think a little bit about how we use the interventions. As we spoke about before, therapy is the first line intervention. This means that children with moderate to severe symptoms related to PTSD should all be referred for an evidence-based, trauma-based psychotherapeutic intervention. This helps to treat individual symptoms and comorbidities. It's important to educate the family on this and let them know that the most effective first-line treatment for PTSD is trauma-based psychotherapy. Medications can be used, but their use is adjunctive. For medications used to treat PTSD, they work better for severe symptoms and may also be used to treat comorbidities like major depressive disorder or generalized anxiety disorder. When prescribing medications for PTSD, it's important to know that there are no evidence-based FDA-indicated medications for PTSD in children. Therefore, all of the medications are directed at treating individual symptoms and are largely used off-label for the pediatric population. This means that when prescribing, you may need to use dosing recommendations for another indication, and you should monitor closely and have more frequent follow-up. Some of the medications that have been shown to be helpful for specific symptoms include prazosin, which can be used at night for nightmares and hyperarousal. Also, propranolol has been shown to decrease re-experiencing symptoms. Second-generation antipsychotics such as risperidone and quetiapine also have some evidence to support their use in PTSD. Clonidine and guanfacine are helpful for re-experiencing symptoms, hyperarousal, and nightmares. Carbamazepine has some support for the use of helping symptoms of sexual trauma. And Depakote also has been shown to reduce some symptoms of PTSD. Because medication use in PTSD is off-label and symptom-specific, oftentimes primary care providers will choose to refer to a child and adolescent psychiatrist in order to prescribe medication. In addition, evidence-based trauma-based psychotherapies are typically provided by a different mental health provider, such as a licensed clinical social worker or a psychologist. This means that the primary care provider will need to involve another mental health provider in the care of the patient. There are certain ways that can help to increase the success of involving another mental health provider. This begins with outlining the roles and responsibility with the family, the specialist, and the primary care provider before engaging care. The primary care provider should schedule close follow-up and assess if the linkage was successful, if the patient has been able to attend their appointments regularly, and especially if the treatment has been helpful. This may mean needing to troubleshoot as needed. Sometimes this means giving a new referral if the patient and family has not been able to connect or feel like they have a good fit with their mental health provider. It also might mean giving more education if the family has questions about recommendations that their mental health provider has given. This might also include communicating with the mental health provider to understand the recommendations and to help support the family in following them. It is good for providers to establish relationships with specific mental health providers who will provide feedback, see patients urgently, and have been shown to successfully work with families. Coordinating care with all mental health providers is an important role for primary care providers. Share care models have evidence for improved efficacy in treating chronic medical problems such as PTSD. Increased coordination of care is linked to better outcomes for patients. Obviously, in the healthcare system, there's some adjustments that need to be made in order to allow for increasing collaboration, as oftentimes there are barriers such as time and billing to prevent fully collaborating with other mental health providers. While any diagnosis and level of symptoms in children might benefit from the inclusion of a psychotherapist in the treatment plan, it is not always necessary to refer to a child psychiatrist. There are some established guidelines on when a primary care provider might consider managing with a consultation, consulting a child psychiatrist, and referring to a child psychiatrist. Let's review. In cases where there's mild to moderate depression or anxiety without psychiatric or significant medical comorbidities, this might be a patient that the primary care provider manages on their own. This is in reference to patients with a single clear diagnosis that may respond well to an SSRI or other medication. For more severe symptoms or symptoms that have not responded to treatment, it is beneficial to get a consultation from a child and adolescent psychiatrist, similar to using the Illinois DocAssist consultation line, where the provider can discuss the case with the child psychiatrist and come up with some ideas about how to continue treatment and move forward. A more formal consultation with a child and adolescent psychiatrist, meaning sending the patient to have an evaluation, might be necessary if the symptoms are getting more severe or resistant to multiple types of treatment. It also might be helpful when there's coexisting substance use or coexisting psychotic symptoms. In these consultation scenarios, the child psychiatrist may provide brief treatment as well as treatment recommendations that can be continued by the primary care provider once the patient has stabilized. Finally, in cases where there are multiple comorbid psychiatric disorders, significant comorbid medical disorders, or severe depression with psychosis and severe suicidality, these cases might benefit from being referred out if available and managed by a child and adolescent psychiatrist. As previously discussed, PTSD is only one potential outcome after a child has experienced a trauma. There are multiple other symptoms that may be experienced. As discussed on a previous slide, the symptoms may be internalizing, like major depressive disorder or generalized anxiety disorder. The symptoms may also be externalizing, like a conduct disorder or oppositional defiant disorder. In the case of a child who has had a trauma and developed major depressive disorder without PTSD or another behavioral disorder, the important line of treatment is to treat the other psychiatric disorders as typical, utilizing medications and therapy as typically recommended for major depressive disorder or a different disorder. There's no difference in the evidence-based management, except you want to add the tenets of trauma-informed care. As previously discussed, the tenets of trauma-informed care are resiliency and healing centered, with recognizing the impact of trauma and ensuring continued safety. So providing the patients and family with continued education about the impact of trauma on the development of the psychiatric disorder that's being managed, as well as monitoring for additional traumas. It's also very important to ensure continued safety for children who have had trauma. This might mean a lot of different things. For children who are the victims of child abuse by a close family member or caretaker, it might require contacting DCFS and providing for that child's immediate safety. For children who have been the victim of another type of violence, it might require education on safety seeking and family support. Monitoring is a large part of treating any trauma-related symptoms. As children grow through developmental stages, different aspects of past trauma may begin to impact them differently. So symptoms may occur at different developmental stages, even if the symptoms were not present after the trauma. For example, a child sexual abuse survivor who is now an adolescent and wanting to have an intimate relationship might begin to experience more significant symptoms related to their trauma. As alluded to in previous slides, one of our roles as providers is reporting child abuse and neglect. The Illinois Department of Children and Family Services has guidelines on their website about how, as mandated reporters, we are supposed to report and when it is necessary to report. These guidelines are good to review because deciding whether or not to make a report can be difficult. However, it's important for us to remember that the safety of the child is our primary goal. One of the most common questions answered on the website are, what are child abuse and neglect? The definition of child abuse is the maltreatment of a child under the age of 18 by a parent or their romantic partner, an immediate relative or someone living in their home, a caretaker such as a babysitter or daycare worker, or any person responsible for the child's welfare such as a healthcare provider, educator, coach, or youth program volunteer. Mistreatment is defined as injury or putting the child at serious risk of injury. Child abuse is defined as physical, sexual, or mental abuse or neglect, which is the failure of a parent or caretaker to meet minimal parenting standards for providing adequate supervision, food, clothing, medical care, shelter, or other basic needs. Utilizing this definition helps us determine when it is necessary to report. As in our previous case, and we recognize that oftentimes family members are unaware that the child is being abused and the child is reluctant to report. Therefore, it's very important to consider, what if I'm not absolutely sure abuse is occurring? The website for the Illinois Department of Children and Family Services gives us more information on this. It lets us know that as many as 70% of child abuse goes unreported, and a child tells an average of 7 adults that they are being abused or neglected before a report is made. Of the more than 1 million hotline calls received over the past 4 years, only about 1 in 4 resulted in a formal report and investigation. Many of the calls do not lead to investigations and are often directed to referrals that connect families with community-based programs aimed at preventing abuse. When formal investigations do occur, only 4% result in children being removed from their homes. As mandated reporters, the suspicion of child abuse can be reported, and it is not necessary to gather evidence or to have an official report from a child. It's also important to know that connecting a family with the Illinois Department of Children and Family Services can sometimes provide more support in helping the family be connected with community resources. As mandated reporters, making a DCFS report is an important part of our job and an important part of keeping children safe. As we conclude our presentation, let's review some key points. First, childhood trauma is common and has long-term impact on mental and physical health. Therefore, screening and early intervention are important. 2 types of screening should occur. Universal screening for all new patients, because trauma can occur in up to 60% of children. Also, selective screening for high-risk individuals, utilizing the risk factors determined in the ACEs study reviewed earlier in this presentation. Screening should begin with initial assessment to determine if trauma occurred, and then follow-up assessment to determine if there are any psychological symptoms present related to the trauma. This may include screening for PTSD or any other internalizing or externalizing disorders. Second, trauma-informed care is not a specific treatment, but rather a framework used to acknowledge the impact of trauma and promote resilience. Trauma-informed interventions should be focused on promoting healing and recovery to allow healthy functioning, and not overly focused on deficits developed because of the trauma. For all children who have been exposed to trauma, whether or not they have developed related psychological symptoms, it is important to encourage self-care and supportive communication amongst non-perpetrator family members affected by trauma. This includes the preventative maintenance interventions discussed in this presentation, such as healthy lifestyle, extracurricular activities, and relaxation techniques like deep breathing and meditation. It is also important to remember that trauma in itself may not require treatment, After initial reporting of a trauma, the first thing to do is empathize and normalize the trauma response, with subsequent monitoring for the development of a trauma-related disorder. Early psychological debriefing can increase risk of developing PTSD and should be avoided. If a clinical diagnosis does occur, remember that impairment and loss of function drive the need for treatment. Children with more severe symptoms and greater impairment might require more intensive treatment. Evidence-based trauma-informed psychotherapy is first line and the best treatment for trauma-related symptoms, especially PTSD. It is good to familiarize yourself with the common evidence-based trauma psychotherapies and the elements that make them successful so that you can provide education and appropriate referrals to families. Medications can be helpful in certain situations, but are off-label for PTSD and typically used to target specific symptoms. For other mental health disorders related to trauma, such as major depressive disorder and generalized anxiety disorder, it's important to utilize the evidence-based treatments for each specific disorder with the addition of trauma-informed support. Finally, throughout the steps of providing trauma-informed care, it's imperative to ensure the child's current and future safety. This may require involving DCFS, as well as providing support to the family and treatment recommendations. Here is a slide with some of the resources used in this presentation. This includes links to the adverse childhood experience studies and some of the screening forms utilized. Additional resources can be found on the Illinois DocAssist website at www.docassistillinois.org. This slide contains the references utilized in developing this presentation. These references can provide additional information on the treating of trauma-related disorders in youth. Thank you for joining our presentation brought to you by Illinois DocAssist. Illinois DocAssist is a program funded by the State of Illinois Healthcare and Family Services. Our mission is to help primary care clinicians screen, diagnose, and treat mental health and substance use problems of children, adolescent, and perinatal women. We do this through trainings such as this one, as well as consultations with primary care providers. For more information or to have a consultation or further education, please contact us at our consultation line or with our email or by our website. Thank you.